for joining us this afternoon. My name's David Kay. I'm one of the trainers for the Patient Navigator Training Collaborative, and I'll be your facilitator for today's session. I'm ably assisted by Erin Martinez from Patient Navigator Training Collaborative, who's handling all the logistics and the technical support. Thank you, Erin. We couldn't do it without you. So if you haven't already, please, in the interest of time, identify yourselves in the chat feature. Introduce yourselves, your name, your organization, and where you're located. And for networking purposes, Erin has already distributed a list of today's participants, so you can connect with each other afterward if you so desire. This is the second in our Supervisor learning series. March 27th, we did a session on writing Patient Navigator job descriptions. Today's session will be on role clarity, Patient Navigator role clarity. And then on May 22nd, we'll have a panel discussion on integrating navigators into the healthcare team. And so again, these are just slices of the Supervisor course, a one-day course that goes into all of these topics in a little more details, a comprehensive approach to Patient Navigator programming. So if you haven't already had a chance to take that course, please check it out. So for today, we'll be talking about Patient Navigator role clarity, and we're joined by Andy Dwyer, and I'll introduce her more fully in a moment. What we'll do is we'll have a presentation from Andy about role clarity, and then we'll break out into small groups, chat rooms, to do an activity, and I'll provide the directions for that when we get there, and those directions will be posted in chat so you can read them. And then the handouts from today's presentation will be distributed via email afterward. Okay, so without further ado, it's my great pleasure to introduce Andy Dwyer, who is the program director for the Colorado Colorectal Cancer Screening Program at the University of Colorado Cancer Center. Andy's going to share her experience with patient navigation in the CCSP program and provide us some key points to think about in clarifying the role of the lay patient navigator. So, Andy, take it away.
Okay, great. So hi, everybody. Thanks for having me today. And Kirsten Legreese is joining in this course, but she's also one of my teammates. So I'm going to have her with me on screen as well. And Kirsten, I would invite you to chime in as much as you like. So let me go ahead and pull up my slide presentation and we will get started. So I think that we have several different folks who are actually part of the CCSP program here, I think, that are joining. I think we've got a couple different clinic systems who have been part of our program throughout the years. And so just, David, can you guys see my screen okay? Are we good?
Yes.
Okay, perfect. So as many of you who've been involved, I think, from the primary care side, the real goal of the CCSP program is to ensure that the medically underserved have access to colorectal cancer screening in a manner that integrates the changes in the healthcare system from a primary care standpoint, as well as thinking about access to colonoscopy and specialty care. And I would tell you that when we started our program many years back, actually it's been about a decade ago, that when we were starting to talk about the program, this was well before ACA expansion. And it was interesting at that time, we were paying directly for the medical services in terms of colonoscopy. And so we had a statewide program that had Amendment 35, the tobacco tax dollars, which has the real thrust for cancer prevention and control as part of one of its main mission and goal. And at that time, colorectal cancer, and still today, is one of the leading causes of cancer death. So what was interesting is when we started this program, we really hadn't embedded navigation as one of the central tenets of the work we were doing. We did think a little bit about what were those care transitions between specialty care and primary care for people who needed colorectal cancer screening. But the navigation component really started to become the need became really apparent as we started to grow our program working with our specialty providers, because when we were working with people who did the colonoscopies, who did endoscopy, a lot of time the feedback we were getting was that ultimately our program paid a really fair price for the screening exams, but they just said, you know, that's not really enough. We need to make sure that people are fully prepped for the procedure, that they have the appropriate rides because of the sedation, that they're even aware of their anatomy, that, you know, so many people were even confusing the difference between a colposcopy and a colonoscopy. And so there was a lot of work to really be done in this area. And so when we really took a step back, you know, from our initial approach with CCSP as just a means to pay for screening exams and having the university coordinate that, we really actually started to really embed a lot of the navigation approaches that at that time were really affiliated and really oftentimes connected with treatment navigation. But we were really trying to think about that role and function of navigation being barrier reduction, access to care, allowing the rest of the entire healthcare team, so within the primary care setting as well as at the specialty setting, that everyone was working at the top of the licensure. So in 2007, we had a grant to move forward with colorectal cancer screening. Navigation was a big part of what we were really moving ahead. And we were really excited because from our first 10,000 screens in people who were screened for colorectal cancer, we ultimately found that in our program, we had our no-show rate less than 10%, which before the program, we were hearing that a lot of times the referrals were made, and about half the time, people weren't showing up, or they were even showing up that they didn't have the adequate bowel preparation, so they couldn't do the exam in a way that was responsible enough to look for or for polyp growth and the like. So our no-show rate was less than 10%. Even to this day, it hovers about 8% with the use of navigation. Our bowel preparation rate and ability to reach the cecum, about 95 to 97% of the time, people were showing up with clean enough bowels that they could actually advance the colonoscopy equipment and the endoscopy equipment and the colonoscope in, that they could really have a good exam, something that warranted, you know, basically being able to look at the actual tissue, find and remove polyps. So we were really excited about, you know, the impact that we were seeing in screening and early detection navigation. And so when we continue to move forward with CCPD funding over the last couple of years, and since ACA expansion, we've definitely seen the real opportunity for screening navigation, and that's really that's really the thrust of what our grant is about these days, given that ACA is happening. People who have Medicaid are largely covered for preventive cancer screening. So we really just saw the power of navigation kind of in a happy accident. But in the end, we really saw the principles of navigation could be very much applied to breast, cervical, colorectal cancer screenings. And we've really, I think, probably as much as anyone throughout the country, have a dedicated approach to doing this, and one of the largest preventative screening navigation from a statewide type approach, working with the medically underserved. So continuing in this work, and we're going to really get into the discussion about the role and scope, is that at this current time, our program, CCSP, is embedded within the safety net clinics throughout Colorado. We have about 30 different clinic systems who are participating, and then that ultimately is about over 100 individual clinic sites who are navigating on behalf of the program. But essentially, we're seeking to reach people who have an income level at or below 400% of the federal poverty level, who have any type of insurance based on Medicare and Medicaid, privately uninsured or privately insured, as well as the uninsured, to ensure that they really think about the goal of colorectal cancer screening based on age guidelines, medical guidelines, and the like. And part of our big thrust, of course, is to try to make sure that we hit the 80% by 2018. And we know that this designated safety net and the medically underserved are still a huge part of the population we want to reach to elevate this overall screening goal. In that, I think when we started the program, our screening rates in the medically underserved was less than about 20% of the population. And so right now with the Medicaid population, what are we at, Kirsten? I think we're, based on our estimates, we're at 35 to 40% of those who've had Medicaid. So we are seeing gains. We just want to make sure that we're really thinking about the role and scope of preventive screening navigation, because this is truly one of the types of cancer that can be prevented. And we've definitely, with those stats that I showed and that I spoke of earlier, that we really have shown that navigation makes a huge impact. But we didn't get there without doing a lot of dedicated approach about thinking about what is the role and scope of navigation and how does that fit with thinking about working with the rest of the healthcare team and role clarity. So what I have on screen right now is essentially the fundamental aspects and the core areas that we think about when we think about preventive screening navigation, and really think about the roles and how this fits together. So I'm talking about these in sort of general categories, but we really think that these are fundamentally the areas where navigators touch to make sure that that patients are truly prepared, they understand the intent of the exam, they identify their role as a patient, and they really think about how to move forward with using the opportunity to learn from this experience to really apply this sort of fundamental self-empowerment, really advocating for your own health moving forward. But what I can also tell you is we're going to go through a step-by-step scope of practice type piece in great detail, where we can really suss out the role and scope of Navigator with connection to the rest of the healthcare team. But what I wanted to say is that when we really think about the power of navigation, this is really fundamentally the core areas that we're talking about. So when we think about in-reach and outreach in navigation, we know that there are definitely people, and we'll use colon cancer as an exemplar. Essentially, there is a way to really look at within the electronic health system and other types of dedicated means, understanding who's eligible to be screened for colorectal cancer. So I gave the general premise, we're looking at people who are 50 and over who meet those criteria for our program and who are in need of population-based screening because they're average risk or people that might be at high risk. So when we're thinking about in-reach, we talk a little bit about the navigators really ensuring that they're working with the rest of the healthcare team to really understand who's eligible, keep this area of cancer prevention on their radar. So in that sort of sense, we see navigators playing a fundamental role in things like group huddles, making sure to help with coordination around the EHR, EMR, so that we're getting a good sense of who's maybe on the docket, who are patients who are going to be seen, and how do we prepare to talk about the colorectal cancer components that the patient might need to really help think about their own identification of need to be screened. So when we're thinking about clinic in-reach, we're really thinking that there's, of course, that huge opportunity for navigators to help with the rest of the healthcare team work to identify who is eligible and how to reach this population. And then we also send in this component also outreach, because we know that a number of our navigators work with community health workers or other initiatives within the community where patients are making that connection into the primary care medical home. And we definitely see a role where navigators can help be a part of that warm handoff. And some of our navigators specifically actually work out in the field to do some of these outreach components at health fairs and the like. But by and large, most of the activity for the navigation for CRC happens within the primary care home. We just want to ensure that we're really thinking about the role of the navigator in the in-reach outreach. As noted, a lot of times we were hearing that from the education component, the understanding of what is the exam, what's entailed, what is the benefit, and what are the pros and cons of having an exam, particularly for a colonoscopy, which has been our focus, has been a huge part, knowing anatomy, as well as thinking about how do you adequately prepare. But what I would also say is that we really, in the last year or two, also thought a lot about what are the other screening modalities and how does the navigator work with the rest of the healthcare team so the patient knows the menu of options. When we talk about communication, we're really getting at fundamentally communication between the doctor, provider, and the rest of the healthcare team, but also then navigators communicating with patients about the value and really what are the core components of navigation, or excuse me, that need to be communicated so that the patient sees their own risk, their own opportunity to be screened, has a good, really good rapport with the rest of the healthcare team, and that they feel like they're adequately set to move ahead, and that they have a really good opportunity to discuss any fears, any opportunities, and thinking about some of the other healthcare issues that might be coming forward. And then barrier reduction, of course, is an area that we really spend a good amount of time in terms of thinking about what are some of the structural barriers when we think about perhaps what are the provisions that people need to think about for transportation, having someone escort them to and from the appointment because of the sedation. And we really think about within the appropriate context of the navigator, what is their role? And I think this is one of the areas where we see the navigator for role and scope really thinking about their particular idea, because a lot of our navigators really know the resources, know the community, know the cultural, linguistic issues that are coming forward. And we see a lot of the navigators really working towards the barrier reduction. And this is an area that has been key, and I think a facilitator for the rest of the health team to really champion the role of navigator. And then we particularly have put in the idea of thinking about reminder systems, in that CCSP, as well as our program partners, have really worked with a lot of the the specialty care providers to really think about the bowel preparation needs to happen a day or two in advance. If there's actual medications that need to happen, reminders about blood thinners and the like, there's reminder calls about when and what to really think about from the dietary piece for the bowel preparation, from really thinking about how to most adequately prepare, as well as really thinking about who they need to have, escort them to and from the appointment. So this reminder piece has been a huge function that we've actually worked with a lot of the specialty providers, schedulers, and the like, to really define who is the best person to work with the patient for this reminder. And a lot of that, again, is really thinking that the role of the CCSP navigator is someone who completely understands the specific issues and barriers that might be common to the population, to the specific urban or geographic area where the clinic is placed, or where the patients are referred from. And so we really actually have thought a lot about, even with that scope of practice, who is the best person to do this. And a lot of times, even with working with the specialty providers, the role and scope of the navigator for CCSP, it's been very clear that they should be serving this role. But if not, we actually also just figure out who's doing what. And that's something that we'll really talk about for each one of these areas coming forward. And then, of course, for care coordination, if there's an adverse event, polyp removal or the like, and I'll talk about this in context as well, is that we want to ensure that although the navigator will never be the one who's giving directly the results of the test or talking about very prescriptive medical diagnostic or information, or recommending specialty care, the nurses, the doctors within the primary care clinic and specialty care clinic will be the ones to do that. However, we do know that ultimately the navigator will help with barrier reduction for treatment, for any adverse event, and then in terms of also ensuring that the patient understands, we ensure that our navigators follow up with each person, that they're clear about the course of action based on the findings of their specific diagnosis. And even if there is no problem at all, just making sure that there's ultimately a follow-up, so that the patient understands that if a colonoscopy is done and it's a completely fine exam, that in 10 years they need to have that follow-up. So when you really look at this step, these are the critical pieces that we know that people need to have in place to ensure that they have a good colorectal cancer screening experience, that they show up for the exam, and that they're adequately prepped and they get the type of screen that's most responsible to really make sure that we're preventing colorectal cancer or finding it early if that's the case. And so when we really think about this, and I touched on, where we see the navigator fitting in, but it is really in terms of role and scope. We're going to talk a little bit about that in more depth, but these are really the fundamental domains. So let me just stop there, because I have Kirsten who's with me, I have David and Aaron. Is there any sort of clarification right now? Because I can keep moving, but I also want to pause because I know I talk a lot and I know I talk fast. So David, anything particular?
Well, let's wait and see if the group has any questions. So far, so good.
Okay, very good. So when we really talk about the role of the patient navigator, we really think about, and I focused on this again, the elimination of barriers to cancer screening, improve access to health systems, enhance the quality of patient care that's received, and promotes continuity of care. So when we really think, one of the things that I had mentioned previously is that we had seen a lot of devotion towards cancer navigation from the point of diagnosis forward. But I think what our program has really also hoped to put forth as well is in the area of navigation, and that the rest of the health team sees that really the value of using navigation in prevention and early detection. And that with our program, we've seen that this typically decreases patient anxiety associated with the medical services by, again, if we go back to the slide, making sure there's all of these touches and it's very clear about who does what, and that the navigator ensures that we really hit these pieces and that they know their own place with each one of these specific domains. And that we also know that with use of navigation, this increases patient follow-through and satisfaction with health services. So we've done a number of different types of quality control type initiatives through CCSP to ensure that the navigation we're providing, the level of care, that people really do feel like they were educated, that they're ready for their exam, they understand the importance of the exam, and the navigator has played a huge role in that. So I think I said this earlier, and I know this has been a huge part of what we've talked about previously, but we want to also just say that team-based care, that we really are looking, the navigator allows the rest of the healthcare team to work at the top of the licensure. So when we've talked about this scope and role, what I would say, and I made some specific discussion around these areas about who's doing what in the general schematic. But what I would say is that we heard from doctors and nurses that a lot of times the navigator who's working within their team, and I'll give you an example at Marillac Health, there's a nurse, there's a mental health behavioral specialist, there's a nurse, there's a doc, and there's a navigator who work. And really in that sort of type context that it is truly team-based care, it allows the doctor to really focus on the medical care, the piece around the diagnostic portions, the nurses to assist with that and really think about some of the medical components around really thinking about that care coordination around the very specific acute issues around medicine, around really thinking about how do you really think about a specific diagnosis and all the other medical, heavy-duty medical components, and the behavioral health specialist working in that group as well for the really acute health issues. But what we hear in this sort of approach where we truly have team-based care is the navigator is also oftentimes the one who can bring in what are some of those other issues that might be related to social determinants of health, what are some of the issues that might be barriers that might not otherwise come forward, and that the navigators who are within this team really understand the resources that are available, spend a lot of time working with barrier reduction and the like. And so we really get that role and scope of who is doing what, but everyone sort of understands this overlap in terms of where does a navigator start and where does a navigator stop. And we're going to talk a little bit about how we really suss that out based on our program. But that's ultimately we see team-based care is when everyone really gets a chance to work at the top of their licensure. And then ultimately who does what is very different and can be different within each clinic system. So an approach that we've come up with CCSP is making sure that we hit some of those very big components and competencies, but we've made some very dedicated and concrete activities under each one. So that way each one of the healthcare teams can bring this specific form, which I'm about ready to show in a minute, to really suss out with the team about who's doing what. And as noted, because we have specialty care partners in that as well, we know that there actually has to be the provision to understand role and scope of the navigator, maybe not just with the primary care team they're working with, but also the referral team members who might be a GI center separate from them. And we'll go through that in a minute. And I just want to also say the following. I think when part of the reason for developing some of these worksheets and the things that we have is that Dr. Farley once told me from Salud Family Health Center, who's our medical clinic, when I was trying to do broad over-sweeping statements about developing this navigation program, is he said, you've seen one clinic, you've seen one clinic. And I think everyone said that, and we needed to find a way that we allow navigators to truly do the work of navigators, but we needed to allow an opportunity that they could really think about within their specific setting, how do we delineate scope of practice and who does what. So, and then a couple things that I just want to make sure that we have definitely pointed out is that, and I know that this has probably come up in some of the general navigation training, but we've always tried to stress also team-based care and role and scope. The patient is really part of that as well. And we also want to always make sure that the patient is at the center. No one should be working harder than the patient, but the real end user should be the patient. So one of the things that we try to definitely think forward, moving forward, is also what is the patient bringing as their own resources, and that we're not jumping in for barrier reduction if it doesn't really need to happen. If there's other resources, that we use this grant, we use the resources that we have for people who really need some expressed specific types of resources. But if a navigator has a friend or family member who can help drive, someone who's also there to help with the reminder component, we really think about the value add of the patient, and that the navigator is really thinking about that as well. And then, as I noted, the navigator should never be giving the direct medical advice or the initial results of the test or recommendation. And that's something that we try to make sure, because we do have a component, as noted, that we ask navigators to follow up with people to ensure that they're actually getting their tests and results. That can be a little bit of a fine line, but we talk about the real role of navigators and having to help facilitate that discussion, that if someone is confused about that initial result or didn't necessarily ask questions to the doctor or nurse, that a navigator can really help facilitate that connection with their rest of their healthcare team, as well as the patient as well. So I just want to say, in terms of role and scope, that's something that's quite essential as well. So what I'd love to do now is to jump into our actual CCSP step-by-step roles and responsibilities. So let me go ahead and do that here. So David, do we want to stop and pause it all for questions, or do you want me to just jump in? You're on mute, sir.
Mute myself, thank you.
Okay.
I have a bad habit of forgetting that. Why don't you go ahead and jump into the tool, and then we'll take questions.
Okay, excellent. So I've gone through this, and I don't want to duplicate completely. I'm here, or hold on just a minute. Can you guys see the, which one can you see right now? Are you seeing, you're seeing this step by step, right, David?
I don't see it.
You don't see it. Okay, let me stop share really quickly, and I will reshare the screen.
Yeah.
Share screen.
Here you go. Well, it came up for a moment.
Is it there?
No. There you go. We can see it now.
Okay, it's there? Okay, excellent. So
well, I don't see it.
All right, it's playing peekaboo.
Yeah.
There we go.
Okay.
David, are we good?
Yep.
Okay. So in terms of really thinking about those broad categories, and you'll see that they're largely the same categories that we talked about in terms of core competencies in areas. The area that we have, what we have tried to do to ensure that we think about that context of each clinic system having their set flow, and the idea of what the navigator is going to do, and how does that really fit within their own clinic staff as well as their partner organization, is under these big headings, which you saw earlier, is ultimately went ahead and delineated what are the specific tasks. And so what we do within our CCSP training itself is we do go through a much more robust discussion about the role of navigator, go into all of the areas around care coordination, communication, very specific case studies around reminders, barriers, and the like. But after going through that sort of detailed approach, we spend time within our training to have the navigator, with the rest of typically other navigators, really see this step-by-step piece. And so just to give a couple of examples, for instance, in the InReach, identification of clinic patients in need of screening, they spend time thinking about how that's going to happen, who does that based on the discussion of role and scope of navigator, thinking a little bit about verification of income and insurance status. And just to give you an example here, for example, is at Denver Health, our navigator who works, Diago, who works for CCSP, is really devoted towards education, barrier reduction, reminder, and care coordination, because a lot of times the insurance coverage is already happening within the enrollment office at Denver Health. And so he knows exactly where to find information about his patient and client information around insurance coverage and the like, but he himself is not directly involved in that component. So we know that he can also just really go through and think like, okay, who's doing this component? But what you'll notice is that we have talked about what is ultimately needs to happen at every step of the way for a patient to actually come through to have successful colorectal cancer screening. We've broken those down, and in some situations like a rural community, we know that a navigator might be doing most of all of this work, Whereas in a healthcare system like a Denver Health, where you have an enrollment office, there might be someone else who's doing this specific component. So what we have specifically dedicated is what are these concrete tasks, what does it mean to navigate all the way through, and we also then give that provision that if someone has an in-house pharmacy, an enrollment office, or even people who are even specifically devoted towards data and enrollment on behalf of the program for evaluation, that we really think about their role and scope. So what you'll notice, of course, is that in some situations that this is super critical for if Kirsten is a physician and I'm the navigator, at the time of the CCSP training, we pull this together, it's used at the time of the actual training, but then I bring this back as a navigator to the rest of my healthcare team with Kirsten and the rest of the team and say, this is really what it means to navigate for colorectal cancer screening. This is really what we're talking about for being a partner within this program. How are we going to make sure that we're all very much clear about scope of practice? And we make sure that, of course, that this is completed for each one of our clinic systems and they spend dedicated time. And then what we do find, of course, and I think we've always seen those concentric circles where it's like navigator, nurse, or whoever it might be, and there might be areas of overlap. This is huge for bringing that discussion together so that if there is overlap, we can understanding exactly who is doing what and taking that time to really dedicate and devote. So I give this as an example. I think this might be a slightly older version from what we do currently, but this gives a really good idea within one program specific to one disease type about under each one of those general competency areas where navigators should be doing work, or definitely the rest of for team-based care we need to hit, that we're really understanding what is the navigator doing and what are they reconciling with the rest of the healthcare team, but also taking into provision, again, that we're not allowing navigators to do the things that are really complicit with being a doctor or nurse or outside of their own skill set. So I know we don't have a ton of time to go in this, but David, does that hit the key areas that we hope for the general scope of practice?
Yeah, I think that was very helpful. I hope everyone else found that helpful. Does anyone have any questions? I don't see any in chat.
And feel free to unmute yourself and shout it out too.
Yeah, thanks, Erin. Okay, seeing none, this isn't your last opportunity to ask a question. We're going to break into small groups now for a few minutes, for about 15 minutes, and then we'll all come back together and have further discussion. We can ask Andy any questions that come up in the interim. So as you heard Andy say, the challenge here is to have that delicate balance between being clear about what everyone's scope of practice is and practicing at the top of their scope, and yet having flexible problem solvers. So you can't, you have to have some balance there. And Andy shared with us one tool that might work to document that. Andy, I just quickly, how often do you all, or do your clinics revisit this to make sure that what's on the paper is consistent with the reality to mitigate sort of scope creep?
Yeah, and I'll have Kirsten jump in here as well as our navigator coordinator. What I would say is this: anytime there's a couple things. Anytime there's a new team member, it's essential that's happening. I know that we have some navigators who work across several different disease types, and this is integrated within several pieces. So anytime there's any new addition to a team member, any new addition to their scope of practice around their navigation efforts and workflows, that we actually ask folks to do that as well in those sort of, kind of real need because of, obviously a disruption in the system. And then Kirsten, we typically have monthly navigator calls, and so we bring this forward. So Kirsten, do you want to talk about that?
Yeah, so this form is being filled out at the very least every time that we are there for either a statewide or regional meeting. As Andy mentioned, anytime there's staff turnover, we make a real effort to either visit those clinics in person or via a virtual webinar type meeting. And yes, we do have our monthly webinars with all of the patient navigators, and that's a great opportunity for clinics who've had recent staff turnover to introduce their new patient navigators to the greater network of CCSP navigators, and then open up the floor to any questions about role and scope, role clarity, and so forth.
So, and I think, Kirsten, that idea about visits, I think if we ever see something really break down, and this is probably something that I think a lot of folks struggle with, is also that connection to specialty care providers. So if we see a change in a new staff member at a new clinic, or they redo their protocols, so, you know, it's very likely that a lot of times that a GI group will do reminder calls. But if it's not clear that who's doing what, you know, the patient can get annoyed because there's duplication and there's 2 or 3 people calling. We see that happen on occasion where it's overboard. And then we also see the situation where if a clinic system has not made that appropriate touch, you know, team-based care is internal, but it's also the medical neighborhood, especially if you're referring out. And so I think that's one of the things that we've had to really strive, is to make sure that our primary care clinics are making the time to work with their specialty providers, going through this list about who does what. And when we fell away from actually paying for the exams and that we're just navigation, this has been a really difficult thing. So David, to your point, going back to this thing to say, where did it fall off? Where did it go wrong? And reworking those steps and making sure you're including everyone is critical.
Okay. Thanks. So periodically revisiting who does what is useful. So let's break into small groups. And I think this is just random. Is that right, Aaron? We're just breaking people up randomly. What we'd like you to do is just network in your small groups. And the instructions I'm about to give will be posted in chat. So if you don't get everything I say, you can read it in the chat feature. And I don't want to forget, let's post the tool on the screen so people can see it along with the chat. So what I'd like you to do is just discuss with each other how your organization currently ensures that everyone on the team is clear about the scope of the navigator's role, and how do you keep that information current. And secondly, can you use a tool like this step-by-step process flow that Andy shared with us, and what changes would you have to make to adapt it to meet the needs of your work? And so while you're discussing what you do and whether you could use this tool, make note of any challenges that have come up in your work around lack of clarity with things like patient education or medication adherence, or discussing test results and next steps, answering patient questions, anything where it's gotten a little fuzzy and you've had to take some steps to clear that up. And share that with us at the end, time permitting. And so please assign someone, if someone in the group could just take the responsibility to kind of make some notes about what came up. We'll turn you loose into your groups. And again, the instructions will be in the chat because that was a mouthful. And then we'll bring you back about 12:50. We'll give you a 5-minute warning before we're about to do that. Did I miss anything, Aaron?
Nope. So unfortunately, we can't share the screen in the breakout room. So we will send the tool out that Andy shared afterward. But
okay.
Yeah, I unfortunately can't share that during the breakout rooms. But yeah, this is just a chance for you to connect and discuss with your peers. And if you will try to check in to make sure the audio is working, I have a few I'm going to check in on because I know there's different ways we're connecting today. So with that, you just have to accept the pop-up button to go into the rooms, and you should be sent there. So we're going to give it a go. All right, I'm going to bring everyone back to the main session. We can debrief. All right.
Thank you.
Welcome back, everyone.
Yeah, welcome back. We hope that was a productive opportunity. So first thing, are there any specific questions that people have that were not addressed during Andy's presentation? Okay. Someone indicated that the chat feature didn't have the questions. I apologize for that. Anyone want to share the highlights of their discussion? In one group that I went into, I heard about the challenges of large systems, hospital systems, with so many different variations on particular roles like navigation and the challenges around that. Does anyone want to share anything about that or anything, any other challenges they've had with role clarity, role overlap?
Sure. This is Morgan nesting in with Centura Health. So we're a large health system, and we have predominantly nurse navigators throughout our system. We do have some mammography imaging patient navigators, things like that. We've got folks in different areas that would fall into the kind of patient navigator heading. They're just not in every clinic setting and not necessarily consistently utilized throughout our system. I think looking at the research, a lot of the benefit of patient navigation, particularly lay patient navigation, is early in the continuum of care. Certainly, there's an argument that could be made that nursing has a direct clinical benefit, even late down the continuum of care when there are complications or problems and things like that. But a lot of the data about patient navigation specifically has to do with early screening, early diagnosis, early intervention, at least in cancer. Sorry, my bias, cancer. But within that context, so there's a little bit of role sort of disparity there. Hospitals are very often more comfortable plugging a nurse into the role, but is a nurse really needed to do a lot of those things? I'm actually posting and hiring for a role now that will be on the lung screening side, with the knowledge that by the time the patient is actually screened, surveilled through lung nodule, and then progressed to lung cancer, we'll have a nurse on that side of things. But on the front end, where it's a large screening population and we're confirming that they're appropriate for testing, kind of like Andy's description of making sure the patient is ready for prep, has been through thorough prep, that we could utilize a patient navigator in that role and make sure that they continue to get their screenings appropriately and follow up.
Thanks, Morgan. So you will be hiring some lay navigators.
Yeah, it's in the works.
Good, good. And will a tool, will something like Andy's tool be helpful in that? Was that something you think you'll use?
Immensely, because I've never oriented one before.
Okay, great, thank you. See, we have a question here. I was wondering if this webinar is recorded. I missed the beginning portion. I think the answer is yes. Is that right, Erin?
Yes, we will have it available probably within the coming weeks, probably not right away, but we will have a recording available, yes.
Any other questions or something, another experience someone wants to share about how you make sure everybody is clear on their role in your organization?
Yeah, I was wondering if anyone has any particular challenges that they want to throw out to the group. And I know we're close on time, but if you have any challenges you want to throw out, and it could be get some feedback from the group.
I think this is Debbie, and I work for Sangre de Cristo Hospice. And I think the biggest challenge is getting people, and we're talking about the upper management, to understand the lower areas as far as what each role is. I think when you're starting off a new program, everybody's kind of scrambling like, well, you're supposed to do this, or you're supposed to do that. So we don't have a clear clarification of everybody's role. They're working on it. So I'm hoping within the next couple of months that that's going to be more clear. But I think for a patient navigator, that's extremely important, so we know where we need to be or what we need to be doing, not overstepping people's.
Yeah, thanks, Debbie. That's the real purpose of this, is you really need to write this down and be clear, and then periodically revisit it to make sure the practice is consistent with what's on the paper. Andy, we have a question here. Does anyone have any feedback on how to get buy-in from staff and doctors for a new patient navigation program? What do you think about that?
So I would say that there's a couple things I'd be interested in what others think too. So I know for CCSP, at least, when we were recruiting a new clinic, and I think that I've ultimately seen that physicians in the end end up being some of the biggest champions when you show the value. I think that when I shared a little bit about what are the evaluation metrics, which is part of something that I think you have to show. So when a proven program that we have, and in the literature, I think there's talking a little bit about the value add. So for, I think as Morgan said nicely, for screening navigation, there's a lot of really good data that exists. And even from CCSP, we've contributed to that and have more papers and the like coming out. But when we talk about, a no-show rate that is less than 10%, we talk about patients coming forward, and then we talk about the GI and the specialty providers are really a big advocate of this and are more likely to partner as a result. I think you have to sometimes think about what's in it for them. And so I think, the elevator speech that PNTC talks about, even to say, the role of the navigator to the provider can be ultimately that I'm here to help assist you for barrier reduction, allow you to be a doctor to do the things that doctors do. Here's the proven data that suggests that navigation is helpful. So I think that's one of the ways that we've been able to definitely do that. And I think we've had some skeptics, but I think in the end, the same people who have not been quite sure about it, once you go through a deliberate process and approach to make sure everyone's clear about their role, and you have to be, I think, very clear about that so you're not stepping on toes. But as soon as everybody's on the right seat on the bus, they really get with it. And even we choose to have sometimes physicians, nurses be the ones who tell the story of the value of navigation so others can hear it. So those are a few things. Kirsten, I don't know if you had said something else.
Basically everything Andy had said is what I was thinking. But then also, depending on who you're talking to, just honestly, the money game, the return on investment that a patient navigation program can bring to an organization, the dollars saved in proper preps, colorectal cancer specifically, because that's our game. But being able to show the dollar value and benefits of patient navigation has been shown to be really helpful. Again, depending on who in your clinic leadership you're talking to.
Great, thanks. So our time is up. I just want to make a couple of points before we part. Morgan has shared with us that in the chat feature, AONN has standard metrics also, including return on investment. So use those. Morgan, what's AONN?
The Academy of Oncology Nurse and Patient Navigators. So it is lay and licensed. So if you're in oncology, which I will grant you is not everyone, but it is a good starting point for metrics for navigation. So without having to do a whole lit search, you can get a good idea of three. One is patient care, one is ROI, and I can't remember what the other one is because I'm tired. But three sort of areas to use to kind of prove the value of your program.
Great, thanks. Thanks very much. And I would be remiss if I didn't put a plug in for the Patient Navigator Training Collaborative has, again, the Supervisor course that goes into some detail about measurement and program evaluation. And then we also have a level 3 course on evaluation. So that's a good place to start if you're just thinking about starting up a program. What are you going to measure and how are you going to use that information to sell it to the stakeholders? Any final thoughts? Andy, Aaron, before we break?
I just think this question that Alana posed will be a great segue into our final session on team integration, and that's a great question we can pose to our subject matter experts. We will have a panel of 3 presenters and have them present and then do a Q&A for our session on May 22nd. So we hope you can join us.
Yeah, thanks, Aaron. Okay, thanks everyone. Appreciate your time.
Thank you. Have a great afternoon.
Take care.